diagnosis. And even if we talk about this mechanism of direct activation of PGE3, we have to take into account that the other mechanism is very individual this year. The upregulation or downregulation of this receptor, where the clopidogrel works on, is fully dependent on certain circumstances. For example, in diabetics, this receptor is downregulated, so there is more individual response on antiplatelet therapy. This is also, or has something to do with probably clopidogrel resistance in certain individuals, which is very hard to measure in clinical practice. So we have very different responses on clopidogrel, and at the end, if I have a very low response on thrombocyte aggregation, the ischemic risk is increasing. The clopidogrel resistance had been checked in this study. It had been published also from Southeast Asia in the American College of Cardiology. They put in this study, they created a triple group of anticoagulation. Not only dual anticoagulation, thrombocyte anticoagulation, but on top cilostazol. And they saw and they could document that the activation via the ADP mechanism is significantly better in the triple therapy group. So you can say, or you can conclude, or they concluded, that the clopidogrel resistance may be treated or can be treated using cilostazol. And as I already mentioned, in diabetics, this receptor is upregulated. We know that from structural research, that this is upregulated, so the whole mechanisms with the normal dosage of clopidogrel didn't work, or doesn't work. So it may have a benefit if we probably give all diabetics cilostazol just to overcome or to treat the upregulation and less working of clopidogrel if this receptor is upregulated. And there was, this topic was the topic and the purpose of the Optimus II study, which had been published in 2008 by an Italian group. And this was especially in diabetics. And they saw that the activity of this receptor was significantly reduced in the group of cilostazol. They could also measure the platelet aggregation, and this was also significantly increased, the ADP-mediated platelet aggregation, as compared to placebo. So I may conclude that diabetics are really the group who may have special benefit of receiving cilostazol in case of intervention or stent implantation. But I want to focus on more features. It's mediated, this effect is mediated by the CAMP mechanism. And CAMP, this has something to do with matrix, smooth muscle cells. And the antiplatelet effects are also mediated by this CAMP. It enhances inhibition in diabetics, and they concluded that in diabetic patients, abnormally low intracellular CAMP levels play an important role in the suboptimal inhibition by clopidogrel due to the upregulation of this receptor. So the individual response published in Optimus was really, the majority of diabetics were really in this group. Is it also working after bare metal stent implantation? And we have this trial already published in 2003. 705 patients, a controlled randomized trial, and at 19 sites. And you see, restenosis was significantly lower in the group of add-on therapy with cilostazol. Is it also working in drug-eluting stents? Efficacy after drug-eluting stents, data from the Park group in Korea. And as you can see, the TLR was significantly lower in the group of add-on cilostazol as compared to the dual anticoagulation after drug-eluting stent implantation. So they were looking for certain mechanisms, and they found in animal tests that there is an upregulation of a certain phenotype in patients with sirolimus and everolimus. And they concluded that this upregulation can also very good be influenced by cilostazol. So the efficacy after DES implantation had been shown in this study, especially also in the subgroup of diabetes patients, published as the DECLARE diabetes study. Also here you see significant less TLR in the diabetes group after implanting a DES with a triple therapy. Safety. This is a major concern during the last couple of weeks. And these studies, the AMC study from Park and the DECLARE diabetes study, they looked also at the incidence of stent thrombosis. And the AMC data clearly showed also that in the triple therapy group, stent thrombosis occurred significantly less than in the dual anticoagulation group, and the same in this, the smaller DECLARE diabetes study. This is not for nothing. The side effects, and if you use this medication, you get feedback from the first or the second patient. The side effects are predominantly like skin rash, sometimes bleedings, and flush symptoms. So we started, or I started, not to give the patient a double dose, 200 milligrams loading dose like in clopidogrel, but I started to give the patients, first of all, only 50% of the dosage, so I have a higher percentage of patients going on with this medication for a longer time. Otherwise, they will lose confidence and also compliance to go on with this medication. They gave it also in other locations. Also in my institution, we give it also in other locations, like in right here in carotid stenting with cilostazol as compared without. This is all off-label, but you feel the effect. I want to summarize. It's a direct PGE3 inhibitor. So we have no resistance like in, or partial resistance like with clopidogrel. It works also via the cAMP on smooth muscle cells. It is anti-proliferative, and it's also anti-inflammative. I haven't focused on this, but there are many publications on this. The antiplatelet effects by increasing cAMP, it works on this upregulated receptor, which is influencing the clopidogrel working, and this working is suboptimal in patients with diabetics. It's effective in the inhibition of sirolimus and everolimus-induced phenotype and pi-up regulation, which is not present in paclitaxel cells. So we have no difference in the groups between, if you use paclitaxel-coated stents, less stent thrombosis, which is, in my opinion, a major concern to use this substance, and probably also for in the future to have probably after DES a triple therapy. And this, unfortunately, we have more side effects, but you can take care of this in giving this substance, probably not with a loading, but we have no data on this. Probably a loading dose is necessary, but this, what I've presented, it's just some publications where there are no controlled trials on this, so we need more controlled randomized trials to get answer on all these topics. Thank you.
Thank you, Professor Braun.